Hello, this is Kip Creel, President at Standpoint. For nearly 2 decades, we have provided research and counsel to many organizations that want to sell products and services and technologies to healthcare providers. Without question, our healthcare system is vast and complex, and it's larger in size than many countries' gross domestic product. We developed this presentation as a primer for marketing and innovation leaders who want to develop a basic understanding of how our healthcare system works and driving forces. The presentation has become very popular, so we decided to record it to make it available to a wider audience. So thank you in advance for your interest. Let's start with the numbers. Our nation spends around $3.5 trillion annually on healthcare, and that is roughly 20% of our entire gross domestic product and growing. Most of the dollars that are spent are with hospitals, doctors, and other direct-to-patient clinical services. Now, while prescription drugs have indeed experienced price inflation, they still only account for about 10% of total health expenditures. And prescription drugs is where most consumers feel the pain because they are often subject to more out-of-pocket costs. So kind of actually to reach into their pocket and pay at the pharmacy, even though third-party payers pick up most of the tab. But fewer than 8% of the U.S. population is admitted to a hospital each year, and the rest of us really don't experience how expensive hospitals can be. So it's for these reasons that why you hear more noise about high prescription costs than you do hospital costs. The real cost savings to our healthcare system will be addressing what goes on in the provider realm. Who pays for healthcare? Well, it's complicated, so it's easier to look at funding sources received by providers. So private health insurance pays only a third of the funding in our healthcare system. Government sources like Medicaid and Medicare account for nearly $4 and $10. Medicaid is our safety net program for the indigent, and Medicare is our program for the aged or the permanently disabled. Out-of-pocket is 10%, so that's what you and I would pay, like for co-pays or pharmacy or other cash or out-of-pocket expenses. The other 20% consists of the Veterans Administration, workman's compensation, what's paid for federal employee health benefits, and other programs. Most of those programs in the other bucket are also funded by taxpayers. So it's fair to say that the government entities account for about 6 in 10 of all healthcare dollars. This is a simple but important slide. In healthcare, there are 3 domains. You have the payer, you have the provider, and the patient. I won't dwell too much on the patient. I think that's pretty self-evident. But from here, we'll break down each domain into some bite-sized chunks. So let's first start with the medical provider ecosystem. It's big. There's a lot of people in the ecosystem that are providing care to patients. The biggest change that we've seen to this ecosystem over the past 10 to 15 years has been the proliferation of places where patients can get diagnosed and treated. We think that this is a comprehensive list of all the different places a patient can go. And one of the fastest growing areas in the ecosystems are immediate care and retail clinics. So these would be clinics that you'd find in a Walgreens or CVS being the most predominant. What's important to remember is that virtually all decisions about patient care is controlled by doctors. So there are fewer than 1 million actively practicing doctors in the United States. Their decisions pretty much account for nearly 20% of our gross domestic product. Their orders from diagnosis to treatments are then delegated to millions of other people. So without question, the doctor is an important gatekeeper. For the remainder of our presentation, we want to focus most of our attention on the hospital. And the reason, as I alluded to before, is the hospital care accounts for over a third of all dollars in healthcare. And put another way, the dollars spent on hospital care is 6% of our entire gross domestic product. What has happened in my lifetime? Well, a nearly 20% drop in the number of facilities, especially during the 1990s and early 2000s. In addition to the number of facilities, the actual number of hospital beds is down by 45%, also since 1975. Meanwhile, the number of employees working in hospitals is up 87%. So as the number of inpatient beds went down, the number of outpatient visits in the hospitals has more than tripled. And these trends will continue, probably albeit at a smaller pace. Without question, the acute care facility is still the nexus of our healthcare system. The intent of this slide is to help you understand how money flows more or less in our healthcare system. So it represents the payer ecosystem. And there are differences in who actually bears the financial risk and who actually runs the program. There's a lot of crossover and it can get pretty confusing. So for everything I'm going to say, there are going to be exceptions, but I'll try to boil it down to the most common circumstances of who pays and how money flows. So who pays for our health care? Well, as I said before, the taxpayer bears most of the risk. As we saw earlier in the presentation, about nearly 6 in 10 of our healthcare dollars are funded by a government entity. That could be federal, state, and in some cases, counties and municipalities. For now, let's focus on Medicare, Medicaid, and private insurance. Those funding sources are certainly the main attraction. And this is what's represented in the slide here on page 7. So let's start with Medicare. Medicare is a federal program, and all employed people contribute and are taxed at the same rate. So about half of the funds come from the employee, and whatever you pay, your employer is required to match. Medicare is our social safety net for the aged or the permanently disabled, and at age 65, you're automatically enrolled in Medicare. So in short, Medicare is funded by those that are employed through payroll taxes. Medicare also works with private insurance companies to administer parts of the Medicare program. Medicaid is our safety net for the indigent. Qualifying is based on income, and there are formulas that factor in the number of dependents as well. And Medicaid is jointly administered between the federal government and each state. And it's funded through federal payroll taxes and your state taxes. And in most cases, the federal government appropriates funds to each state to administer its portion of Medicaid. And Medicaid also works with private insurance company to manage parts of the Medicaid program. So when a private company, let's say like Humana, offers a Medicare or Medicaid program or insurance plan, providers are collecting money directly from Medicare, Medicaid, or other insurance companies that are administering these programs. And of course, the insurance carriers are compensated for administering these programs. And in fact, Medicare and Medicaid have been very lucrative business lines for some carriers. For the most part, all of the financial risk in Medicare and Medicaid is borne by the taxpayer. If you are not in Medicare or Medicaid, then your options are to buy health insurance directly from an insurance carrier. Your other option is that you will join a plan offered by your employer. For those buying individual policies, you can purchase those direct from an insurance company, or you can go through one of the exchanges established after the passage of the Affordable Care Act. And when purchasing through an exchange, you may be qualified to receive federal government subsidies to offset the cost. Here, the financial risk is shared by the individual, the insurance company, and the taxpayer. Group policies are through employers, and there are some small group policies sold through the exchanges, but they are not common. Most of these are purchased through your insurance company, and here the risk is shared by the insured and the insurance company, who is bearing most of the financial risk in exchange for premiums. So as the costs of these policies have risen, deductibles or copays have grown, which is essentially shifting more financial risk back to the insurer. Among employers, there is another option. Some very large employers are self-insured. And so what this means is that the employer puts money and bears the financial risk. So they then hire companies to administer parts of their plan. And it may be a well-known insurance company. And in that instance, they pay the insurance company a per member, per month fee to do this. And for really large catastrophic claims, self-insured employers will also purchase what's known as reinsurance. So they'll pay premiums to an organization to mitigate the financial risk in those worst-case scenarios. So if you work for a large company, the odds are they are self-insured, but you may not even know it. The bottom line for our system is that financial risk is spread across the ecosystem. And the best advice I have for you is to make sure in your discourse you understand the difference between health care and health insurance. Health insurance is a means to pay for the health care. People conflate the two all of the time, and they are very, very different things. But in summary, slide 7, basically the vast majority of our health care is paid by Medicare, right, which is funded by the taxpayer, Medicaid, which is funded by the taxpayer, or a form of private insurance. And you can have an individual policy, you can have a group policy, and in some employer situations, instead of the insurance company bearing most or all of the risk, the employer in self-insured models bears more financial risk. So it's not a simple payer ecosystem, but again, the bottom line, as I alluded to before, is the financial risk is spread across the ecosystem. What are some of the macro drivers that are influencing how hospitals make decisions? Well, there's 5 that we think are really important for you to understand. One is shaky economics. We'll talk more about this later, but it's really, really tough for hospitals to make money. And there are many hospitals that are not-for-profit, but that still means that revenues must exceed expenses. And a big problem right now is that the costs to run a hospital continue to outpace growth in revenues. So as such, hospitals are very, very cost sensitive. Supply and demand also applies to healthcare. Right now, there is a tremendous imbalance in the supply of healthcare and demand. Arguably, demand is infinite, but we really don't have enough physicians and support staff to meet the growing demands from an aging population. Thirdly, regulatory proliferation is on the rise. The industry is heavily regulated by local, state, and federal authorities. The Centers for Medicare and Medicaid Services, or CMS, is the federal agency that runs those programs, and there is a high level of rulemaking, and we'll talk about the reasons for that a little bit later. And in the past 5 years, there has been a shift in the balance of power between providers and payers. The payer market consolidated first. So if you just look at the amount of health insurance premiums collected, the top 10 private insurance payers accounted for 54% of the market. United and Anthem alone accounted for 23% of all premiums. What's happened in the last 5 years is hospitals have been consolidating into very large systems, rebalancing sort of that price negotiating power that exists between the provider and the payer. And in fact, today, 125 million people in the United States now live in a metropolitan area where a single provider has greater than 25% market share. That'll continue. Lastly, the other macro driver is value-based outcomes. So the traditional model was fee-for-service. So what that means is if I'm a provider, I do a task, I run a test, you have an office visit, and I get paid for each of those activities or each of those encounters. That model is slowly eroding, and the shift is reducing the fee-for-service and paying providers more on incentivizing them to deliver better outcomes at the same or lower cost. More on that as well. But the value-based outcomes is causing a lot of changes in how hospitals approach their decision making. So what's driving this shift toward value-based outcomes? Well, it's largely being driven by Medicare. So as this Medicare system of value-based outcomes becomes more ubiquitous, private insurers will likely follow suit. In short, Medicare is changing the way it pays providers. And there are two programs that they're using to do this. One is called MIPS, which is short for Merit-Based Incentive Payment System, and APM, which is short for Alternate Payment Models. MIPS is an extension of the traditional fee-for-service. So as Medicare holds steady what it reimburses for these encounters or these activities or these tests or office visits or whatever, providers can earn an incentive above that rate for delivering quality care and achieving better outcomes. And providers participating in the program are scored on 4 parameters, and you see those listed there: quality, advancing care information or promoting interoperability, cost, and improvement activities. Quality accounts for 45% of the score, while advancing care information interoperability accounts for 25% of the provider's score. Quality is essentially that, is the provider following certain mandates, delivering quality care, following protocol as defined by Medicare and what's generally accepted as good medical practice. The advancing care information and promoting interoperability is participating in programs like an electronic medical record or e-prescribing, but it's basically enhancing the ability to transmit information. So when a patient goes from a doctor's offices to a hospital or to another care node, that information is easily accessible. So Medicare is kind of driving some programs to enable better information sharing in the ecosystem. The other model, alternate payment model, is still in its infancy, and it basically is a program whereby providers will receive a higher payment for its services and financial bonuses. But in order to qualify, is that the provider must bear more financial risk in what's called a coordinated care model. So it goes back to that risk-sharing scenario. So right now, the way our ecosystem works, providers really don't bear a lot of financial risk. They do a service, they get paid for it. Well, in this case, the provider will bear more financial risk, and in doing so, the thinking is that they have more skin in the game, providing an incentive to lower costs and improve outcomes. How this is done is pretty complicated and probably worth an entire webinar, but it's important to know that it is coming. This program is still in its infancy, so it's a little bit hard to give you much more information than that in this forum. But certainly if you have more specific questions around APMs, you can certainly reach out to us for discussion. So I think it's important to talk about the elephants in the room. So we all know that healthcare is expensive and the cost to deliver care is rising. However, there are really 3 sort of root causes of this, and you don't really hear a lot about this in the public discourse. Number 1 is palliative care. So palliative care is an approach to treating people who have life-limiting diseases, and it encompasses relief of symptoms, relief from pain, the physical stress and mental stress of having a really serious illness or being perhaps at the end of your life. We're getting better, but in the U.S., we don't do a great job of this, particularly compared to other countries. We tend to employ more heroic efforts at the end of life. It's a very delicate discussion, but it's going to involve more education and quite frankly, a cultural change. Secondly, we don't do a really good job of treating the train wrecks, for a lack of better words. So the fact is that the sickest 1% of people in our country account for 20% of all of those dollars. And lastly, there's lifestyle factors. So in the U.S., we really don't own up to the fact that our behavior and certain social determinants, things like tobacco usage, poor diet, lack of physical activity, and poverty are very big contributors to these issues. These are delicate things to discuss, but are really the root cause of why our system is so much more expensive than other countries. These dichotomies that I'm talking about are really apparent when you compare delivery systems, or in this case, hospitals and the hospital systems that exist in rural versus metro areas, or those hospital systems that rely on Medicare and Medicaid funding versus those that rely more on private funding. Scale matters and geography matters. Let's talk about scale. Well, in short, the bigger hospitals in bigger markets are way more profitable. The bigger the hospital system, the bigger the market share, the more profits. And McKinsey has done an excellent study that looks at EBITDA by market share. It's pretty compelling stuff. In rural areas, the number of beds and patient volumes are declining, and that continues to put a great strain on the existing medical infrastructure. In my home state of Georgia, we have 159 counties. 9 of these counties have 0 doctors, no hospitals whatsoever. 64 of the counties, that's almost half, do not have a pediatrician, and 79 of these counties lack an obstetrician. So there very much is a rural versus kind of a metro divide, and it's not just Georgia, it's across the country. As it relates to rural health, I mean, there are a number of telehealth initiatives that work to address these problems, but the current economics are going to make it very, very difficult for the rural parts of the country moving forward. So what are, at a macro level, the key challenges among hospitals? Well, we've covered some of this, but the regulations from CMS, or again, the Centers for Medicare and Medicaid Services, the federal body that's responsible for running these programs. And it has a lot to do with the implementation of the MIPS and APMs. There's been a large set of new rules to kind of make the implementation of these programs, and it's difficult for hospitals to stay on top of these rules, to stay compliant, and make sure that they're doing proper billing. And these are all, directly tied to collecting revenue. If you look at the list, and we only included those that, were 50% or higher in this survey, but most of these issues have to do with things with collecting or building revenue and kind of controlling costs. And again, it goes into the reasons why when working with hospital systems, they are very, very cost sensitive. But there is a formula for creating value, which we're going to talk about a little bit later. So if I had to pull out my crystal ball, these are some things that I think you should count on happening in the hospital ecosystem over the next 5 years or so. There will be a continued consolidation among providers. The data is very compelling because scale matters. And in tandem with that, you're going to see more distributed care and alternate revenue streams. So if you notice that your hospital system is buying up private practices, they're getting into walk-in clinics, or that day surgery center that might have been owned by physicians is now owned by your hospital. And the economics on these acquisitions or these new opening of access points is quite favorable because the return on that invested capital is considerably larger than in these distributed care models than it is in sending everybody to the hospital. And not to mention that, if you can tie patients to a specific hospital system, outside the walls of the main hospital, that's just going to be much better for the hospital system from a revenue generation perspective. Staff productivity is going to be a key consideration moving forward. The vast majority of the costs of running a hospital is staffing. And the midst of very low unemployment, doctor shortages, nurses shortages, the big emphasis is going to continue on how do we allow our staff to do more with the same or fewer people. Workflow impact has always been an important purchase consideration, but its importance will grow exponentially. And so any new product, service, or innovation should really answer the question of its impact on workflow and staff productivity. And the shift to these value-based care models will continue. The pace on this was slow at first, but it's beginning to pick up. And we discussed how Medicare is leading the way, but expect more and more of the private payers to kind of get on this bandwagon. So let's talk a little bit about implications for you as a healthcare marketer or innovation leader. Well, as a result of all of this, the path to purchase is changing. In the past, you could pretty much count on automatic buys from a group purchasing organization or on contract, but that is declining, and most hospitals now, particularly when it comes to clinical items, will be evaluating these items for the best long-term value. They will be looking at both the clinical benefit and the economic benefit of your product, service, or innovation, as things need to be evidence-driven and claims must be substantiated. Hospitals, as they consolidate, are now in a position to do more doctor-to-doctor comparisons and facility-to-facility comparisons, showing best practices and outcomes. So they will use data that you might not even have access to enter that into the evaluation of products or even into negotiations. They no longer believe that buying the latest version of something is the only means to achieve quality outcomes, so newer is not always better. And in the old days, the way to get traction with an innovation was to influence the doctor with the latest and greatest. Today, more and more products do not come into the hospital unless they were reviewed and vetted by a standards committee. Physician preference items are under increasing scrutiny. Physician preference can still matter, especially if the doctor refers a huge volume of cases to the hospital. So really make sure that you don't only lean on physician preference, but you can use it to your advantage depending on the item. Really focus on the benefits and what are the benefits beyond just the direct clinical benefits for the patient. And we're going to talk more about this in the value creation framework. And increasingly, hospitals are asking the degree to which you can engage the clinicians, resource directors, and division directors by offering educational tools and programs to facilitate adoption. Partner with the supply chain managers and making conversion to your new products easier. And really have to get in and know your ecosystem of influencers. You've got quality committees, you've got data analysts, you've got supply chain departments, infection control, and many, many more people that are now involved in decision making. And there was some really interesting research that came out recently that talked about the buying ecosystem in healthcare, that on average there's 6.8 people now involved in getting a new product or new service listed at a hospital. That's a lot. And then also keying into value-based purchasing. So, as part of the decision-making, it used to be the acquisition cost and quality. Today, it's going to be how does your new product, service, or innovation, impact quality, but also what patient outcomes, safety, cost, and employee satisfaction. And that goes back into that key thing on employee satisfaction is really making sure that it's easy for the clinical staff to use, and that it's improving their productivity. And what's the value relative to the patient? I mean, can you get more accurate diagnosis? Can you get quicker turnaround time in the ER? So look for other opportunities in the ecosystem for driving value. So here's a couple more considerations for the researcher and the marketer. I boiled these down to lessons. So lesson one is master the value creation framework. So for any new product, new technology coming into the hospital system, it will be vetted against these criteria. So we talked about a couple of these. So certainly, how will it enable better patient outcomes? They will look at acquisition and usage cost. What we forget sometimes is that if I spend more money in the ICU, for example, could I be saving money somewhere else? So look for how you could reduce cost in the ecosystem. So if you're going to be asking Department A to spend more money on something, how can it save money or improve productivity in a different area of the hospital? Extremely important, because those ecosystem calculations are being made. And then obviously they're going to look at the perceived risk of your proposed solution, but what's the perceived risk of my current solution? And this kind of ties back into the safety profile. So master this. Anytime that you're having discussions about how to frame up the value proposition for your product or your service, use this framework in making sure that you can answer how it relates to this particular framework. Very important. Lesson two is master the ecosystem. And I've alluded to this before, but make sure that you do an exhaustive patient journey or even a product journey or a service journey and understand all of the people and resources that the patient will consume in using your product or service. Look for opportunities to simplify or reduce resource consumption, or increase utilization, or shift to a lower tier of care. So for example, if your technology or you see something that's now being only done by doctors, is that through technology, could that particular procedure or that something in the care continuum be shifted to a respiratory therapist or be shifted to nursing staff and get equal or better outcomes? Will definitely drive an innovation in a hospital. So know the decision ecosystem, know the key influencers, know their individual motivations, and then how can you build an advice-based relationship with each of those individuals in the ecosystem. And lesson three, focus on the benefits of your innovation. So as you're going through, again, defining the value proposition, what is the benefit of your innovation to the patient, to the user, to the whole hospital, or to the whole health system that owns a bunch of hospitals, and to others that are in the patient journey or your product journey. So make sure you really diagram the entire ecosystem. Lesson four, segmentation is going to really matter, and this is segmenting the specific hospitals or even the specific facilities that you want to focus on. So as it relates to physicians, the lines are getting blurred between physicians. So they're looking for new revenue opportunities. Is if you have a new product or a new service, you may default to that, hey, orthopedic surgeons always did this particular type of procedure, but there now may be other people in the ecosystem of orthopedics that may have the ability to take on your new service or your new innovation. So don't limit yourself to legacy here. Look at and understand that the lines between what physicians are doing and the types of procedures and diagnoses that they're doing is really getting blurred. As it relates to selecting hospitals, look at the payer mix, look at patient socioeconomics. That can separate early to later adopters. As physicians, look at the practice characteristics as well. Look at the patient populations that they serve. sometimes that can determine who are going to be provider practices that are going to be early or later adopters. As it relates to hospitals, look at bond ratings and financial health. Go ahead and look at the procedure and service mix that different physicians and different hospitals are doing. Innovation culture is a big one. You will find in some hospitals that there's a lot of inertia around certain innovations, and some hospitals are much, much more on the forefront. This is a qualitative factor, but it is something that can be determined through a research assignment. And then also just look at clinical beliefs and protocols. You'd be surprised how attitudes about certain clinical importance of certain clinical objectives are from hospital to hospital, and finding how much emphasis they might put on a certain clinical belief is extremely important. We do a lot of work in patient nutrition while they're in hospitals, and you'd be surprised at the degrees of emphasis that it changes on how hospitals approach nutrition for patients when they're in the hospitals. So understanding that range of clinical beliefs will help you isolate the types of hospitals that you want to start first with targeting versus with later targeting. So in this presentation, we provide all the sources for this information. If you have questions or you want to discuss next steps, I invite you to contact me. Best way to reach me would be by email. Certainly happy to go through this presentation in greater detail. And we also offer this as a value-added service for existing or prospective clients. We have found that this to be an outstanding training program for young marketers. So if you're interested in having us come in and speak to this content in greater detail, certainly happy to entertain that with you. So thanks again for your interest in our presentation, and I hope we get a chance to work together in the very near future. Thank you.